Well, good afternoon, everyone, and welcome to the March 2016 International Roundtable on Community Paramedicine webinar. I want to let everybody know that we're switching our system a little bit. We're moving from a Google group to an email service, vertical response. And so you should have gotten an email from me directing you to a link to opt in to our future email messages. If you don't have that link and want to opt in, you can go to ircp.info. And there's a link that you can click on the web page so you can opt in to get our future messages. And we've got the lines muted today. We'll unmute those after the session for question and answer time. I'd like to introduce our speaker today. Matt Lyonar began thinking about a career in paramedicine following a high school cooperative education placement with the Red Rose St. Lawrence Ambulance Service in Kemptville, Ontario. After high school, he completed the paramedic program at Conestoga College in Kitchener, Ontario. After completing a Bachelor of Science in Geography with a concentration in geomatics at Carleton University, he left clinical practice and moved to Hamilton, Ontario to complete a Master of Arts in Geography at McMaster University. He's now continuing his graduate studies as a PhD candidate in the Health Research Methodology program in the Department of Clinical Epidemiology and Biostatistics at McMaster. Matthew tries to get around on his bicycle as often as he can. He's an avid sports fan. He loves living in Hamilton and tries to spend as much time as he can with his family exploring the outdoors. So Matt, we'll let you take it from here.
Great. Thanks, Gary. Welcome, everyone. This is it's pretty great to be here, and I'm excited to be able to share some of the work that I did during my master's. Even when I was doing my undergrad in geography, people would often scratch their heads about why I was looking and studying geography as a paramedic. And so what I'm going to talk to you today sort of stems from a post that I did on International Paramedic that caught Gary's attention around data visualization. And the real question is, what is the story that your data tell you? And the tie-in with geography is that maps tell stories. So hopefully through this presentation, you'll see some of the stories that I was able to pull out of the data over the course of my research. So first, I have no conflict of interest to disclose. I'm not an employee of the paramedic services that I worked with during this research process, and I don't stand to benefit directly from any entity as part of this presentation. If you're on Twitter, you can follow me at Matthew Lyonar, and feel free to tweet with the hashtag IRCP. So I raised the question already, what is the story that your data tell you? For some of you, as soon as I mention those words, you might think of two things. One, either reading a phone book, not really all that interesting. Or two, that it's some great literary fiction that is going to be concocted out of numbers that really doesn't seem to be realistic. So maybe I should change the question a little bit and say, what is the story of community paramedicine? Now, here are a couple of my ideas, and I'm sure there might be some common ideas around the globe, really. One is really the sort of adoption of emergency management principles by paramedic services, where when I started work as a paramedic, it was really just about preparation at the start of your shift and response during your shift. But we've included prevention and recovery, and community paramedicine plays a large role in that. But more so, I think there's community paramedicine is a response to barriers or limitations that patients face in accessing appropriate care. And also the development of the paramedic as a clinician, where now, even before my time, some of my mentors would talk about what they would say is the diesel therapy, which is just driving fast and putting a blanket on someone. But the clinician is a role that the paramedic has evolved into, and we take pride in good patient care as other healthcare clinicians do. I think community paramedicine is also a collaboration between other sectors within healthcare, and it's an acknowledgement of patient needs. That it's not just another chest pain call, but here's a patient that we've seen with chest pain 3 or 4 times in the last 6 months. And so then maybe the question goes into, well, how does the data we have tell this story? Or how can we use data to inform the evidence that we need to strengthen evidence-based practice, particularly in terms of community paramedicine? And these are challenging questions. By no means would I suggest that I have the answers to all of them, but I was fortunate to partner with a couple of paramedic services, one being the Hamilton Paramedic Service and another being the County of Renfrew Paramedic Service, both who have shared some of the programs and initiatives that they've done at the roundtable before. There's a real contrast between the two services. Briefly, the County of Renfrew is probably 5 or 6 times the size of the city of Hamilton, with maybe 1/5 of the population. But there's barriers and enablers to accessing healthcare in both regions, and community paramedicine is active in both regions as a response to that. One of the first challenges around using data to tell the story of community paramedicine has to do with how data is structured. And I'm sure that there's lots of different sources of data, integrating data from dispatch or from vehicle AVL systems, ePCRs, and then other documentations and forms. So much of the data that we generate as paramedic services is incident-based. And it looks at, here's a call right now, and this is what happened on that call. So weaving a story together to look at patients over time can be very challenging. And that's something that in my PhD work is a real focus for me to try and generate those patient stories out of data. Other challenges, particularly when you start talking about mapping, and particularly to people on ethics boards, there's concerns around privacy, but this ties into the unit of analysis. And as you'll see in the next couple slides, rigorous analysis really means that individual call locations are not isolated, and the level of analysis is informative to the outcome measures. Other challenges that I dealt with also was just figuring out partnerships with people. I think that there's lots of data that's generated, but the idea of sharing data is something that requires trust, and it requires initiation on both parts to be engaged and interested in finding mutual mutual goals. So having sort of dealt with those challenges and having a set of data in hand, I can sort of talk about one chapter of this story with respect to the city of Hamilton. And within the city of Hamilton, at the time for the time that I had got the data, they were largely focused on their CHAP EMS program, which is set up within community housing apartment buildings. So they didn't have any mobile delivery of service of community paramedicine. And so the question that I asked was, do repetitious users of paramedic services exhibit a different demand for service in terms of space and time when compared to general users? So a little background here. We have two gentlemen. The one in the upper right-hand corner, that's a picture of Hagerstrand. Hagerstrand is seen as the father or the pioneer of time geography in the late 70s, early 70s rather. The basis of a great deal of his work was that people tend to have fixed places that they travel to on a regular basis, in particular work and home. So based on these fixed locations, the other possible locations that they could travel to are constrained by activities that take up time in those places and the amount of time that it takes to get to those places. So the graph that is included here is sort of an adaptation by Cullen and Godson from 1975 to show sort of the typical daily pattern where an individual is at home and then they travel to their place of work and they have a lunch break, but they can only go so far over that period of time. And then after work they may have errands to run here or there, and then they travel home. And in a similar sort of mindset, a lot of the work of Stout around system status management was done. Understanding that over the course of a day, there's a pattern to the location of where calls for service are located. Now, more recently, there's been work done around the temporal or the time of day patterns of use. There's a paper that was just published last year by Cantwell and colleagues that was looking at the temporal model of demand for services for Melbourne, and that was published in Pre-Hospital Emergency Care. There's another paper that was done by Scott and colleagues that was looking at the temporal pattern of the most frequent ambulance callers, and that was posted in Emergency Medicine Journal, I believe in 2014. And both of these works sort of illustrate that over the course of the day, there is a predictable pattern. So in time, we know that there's a predictable pattern, and in space, based on the work of Stout, we know that there's a predictable pattern. And the question is whether or not there's a difference between the general user and the frequent user. Now, another sort of challenge that I had to deal with here was that population is provided in one sort of geographical unit, and the data that I received regarding the paramedic calls were in a different geographical unit. So this slide shows the light blue lines show the dispatch grid used by paramedic services to locate where calls were, and that was the unit that I was provided with. And then the smaller areas within it, or the light gray areas and the dark gray areas, are the units that information around population is provided through Statistics Canada for the Canadian Census of 2011. And so if I want to know information about population and I have information about calls, I needed to come up with a way to be able to marry those two different levels of information together. And so the dots that are on this indicate how I married the census data to the dispatch or the call information data. And I did this for the whole city of Hamilton, and in some areas the 1 square kilometer dispatch grid was maintained as is, and in other areas, because of sort of the rural and outlying areas of Hamilton, dispatch grid cells were merged together. And in the end, it left me with 111 different spatial areas to look at. Now, the other component was to look at the time of day. And we wanted to look at periods of the time of the day that would be informative to the patterns that people move. So we aggregated the data, 5 years worth of data, into one 24-hour period that was broken down into 6 time intervals. Starting at 10 p.m. to 2 a.m. was the midnight time interval. Then 2 a.m. to 6 a.m. was the overnight time interval, and so on back up to 10 p.m. So this aggregation created time periods that generally aligned with the times when people were mobile. So the morning timed in was from 6 a.m. to 10 a.m. That covered morning rush hour. And the afternoon timed in was from 2 p.m. to 6 p.m. So that covered the afternoon rush hour. And so we had 111 different locations and 6 different time periods, and we wanted to look to see whether or not there was this difference in demand for service between the 2 different user groups, the general users and the repetitious users. And I should say here that classification of the repetitious user was more than 4 calls within a period of 365 days, which was somewhat a little bit of a change based on the way that Hamilton classified a repetitious user. Pardon me. They would look at repetitious users as 5 uses within a calendar year. But again, that was changed because the 5 years of data was aggregated into one 24-hour period. Pardon me. So, this is sort of an example of how approaches that could have been useful, and the graph on the on the left is particularly not easy to visualize and not easy to understand, even though I'm talking a little bit about data visualization. And it represents 111 different models of demand for each of the geographic regions within the city. And you can see that there's some differences, but particularly at the lower portion, it's very difficult to determine sort of how one location would be different from another. And the graph on the right is a simple linear model where the number of frequent users is graphed as a function of the number of general users within all of the locations, but divided by the 6 different time intervals. What we really wanted to do was to use one model that could combine both of these 2 different things. And so to do this, we used a generalized linear mixed model. And there's 2 sort of important components of this approach. One was that it could adjust for covariance between similar observations. So basically, at time 1 in location X, there's going to be a relationship between that and time 2 at location X. And then the other element that this approach included was a random slope effect. And in simplest terms, the random slope effect meant that areas with either an increased or a decreased demand by the repetitious users would show up by this random slope effect. And so we ran 3 different models. First was simply just looking at the number of repetitious users and as a function of time. In the second model, we included or controlled for the distance to the nearest emergency department from each of the locations, the proportion that of residential addresses within each of the locations, and the proportion of older adults. And then the third model that we ran also included an interaction between time and the proportion residential and a nonlinear function of time. So all of these things sort of draw together what we know about spatial demand for paramedic services and temporal demand for paramedic services. And we're able to make a comparison between the frequent users and the general users. So what it looks like is this map of the city of Hamilton, where the orange areas, orangish-reddish areas, show locations that have higher than expected demand from repetitious users. And the blue areas indicate the opposite, where the demand is lower than expected. So it's sort of around the, this map shows it around the mean. Say you're either above or you're below, basically. Now, at first glance, the western portion of the city, which is largely rural, dominates with the orange color. But in reality, that's a low number of patients within sort of the whole data set. The the busiest areas, sort of the downtown area, is in this area here. And then what's really of note is that we have a couple of these areas which are red surrounded by blue. And similarly, here we have a blue area that's surrounded by red. So those locations indicate either sort of something really positive happening or something that requires a little bit more investigation. So specifically, this area here, for whatever reason, within this location, we have fewer repeated users than would be expected, and in these orange areas, surrounded by blue, there may be the opportunity for some sort of intervention to look more closely at those areas. It wasn't really surprising to us that there's a high demand within the downtown area. This other sort of blue area here and over towards this area is more suburban, as is up in these areas. So the city of Hamilton is also it's an amalgamated city, and it has two former municipalities, and their downtown areas are also orange. So again, not all of that different than, or not all that unexpected. A couple other key outcomes that we recognized or that we found. One was that over the course of the day, time behaved as we expected that it would, where there was greater demand by repetitious users in the afternoon and the evening. One of the other interesting things that we found was that while we looked at distance to hospital, we expected that the demand would increase with the distance from hospital, but we found the opposite. So there were more repetitious users in closer proximity than further away. Now, with a little further sort of investigation, two things kind of stand out from that. One is that the hospitals tend to be in the urban core, the downtown areas. And then we also found out that there's a large number of social services that are also in close proximity to two of the major emergency departments in the city. And so if there's a way to include some utilization measure of other services in future analysis, it may be informative. Now, if we move on to the Renfrew chapter of this story, I've included this picture here of Sir Arthur Bradford Hill, who is considered the sort of the pioneer, the father of clinical research. And although this chapter is not so much well, it's not a randomized control trial. It is a retrospective cohort study using so it's observational methods. And we looked at do locations that have established community paramedic programs in addition to traditional services exhibit decreased risk of repeated utilization in comparison to communities with only traditional service provision. So during the time which I had data for the county of Renfrew, they had established the Aging at Home program in Deep River, as well as wellness clinics, and home visits in the Eganville area. And I'll point those out in the next couple slides. So a little bit more background around the ideas, the concepts within this chapter. One is the idea of spatial accessibility. So spatial accessibility is a line of study that evaluates services available to a given population based on the distance between individuals and those services. And it often uses a gravity model, so that means that distance and demand at that distance provide the basis for measuring accessibility. One of the challenges with spatial accessibility is that it doesn't tend to account for any person-specific factors. So all members of the population are accounted for in the same way. And it typically results in a score or an index of accessibility, which may or may not be intuitive and usually is not generalizable to other settings. The other challenge with spatial accessibility is that it doesn't reflect actual use. Now, the grid picture in the lower portion of the slide is taken from work by Rossmo. And Rossmo is he's the pioneer of geographic profiling within criminology. And so Rossmo's work was looking at the probability of an offender being located within a certain distance from a crime scene. And his approaches are starting to be used a little bit in epidemiology. Certainly, there is a component of his work that is very intuitive because it's based on a probability, and probability, creating a probability surface or a model, map of probability is something that's easy to understand. Now, the benefit is also that we can generate probabilities using a logistic regression. And so that's what we did, and we took, I'll come back to that in a minute. So we took a bunch of different factors from within the call data and looked at these factors to predict the probability of repeated use. Our data set had 3 years worth of data, so we could look at if an individual was a repetitious user the year before or the year before that, which was a significant indicator of repetitious use. We also found other predictors were age, the rate of their use being low acuity, and respiratory complaints. Another significant factor that was a predictor within the model was location within one of the communities towards the western part of the county of Renfrew. So that was sort of a unique thing, indicating that in this area, there's more demand for repetitious users than in other areas. I'll just back up here. This slide shows how we broke down the county to deal with the rurality issue. And essentially, in sort of statistical analysis, there's that rule of thumb number that you want to have 30 observations within any sort of, to do any any sort of analysis on. And so this is, we used what's called a quad tree to break up the county into areas to ensure that each area had a minimum number of observations. And so in some of the locations, the squares are quite small, where the communities are, and then in the spaces in between, you can get some very large, areas. But this enabled equal comparison between the different areas. So as I had mentioned before, Eganville was one location with an intervention ongoing, and Deep River was the other. So here, these maps compare the predicted probabilities with two different sets of data we used for validating the model. And what's notable here is that, so Eganville is around this area here, and Deep River is up here. And even in the locations sort of neighboring, you can see that the model predicted that there would be greater demand than there actually was. What that means is that these interventions were having a positive effect within the period of study. That based on the baseline modeling, there were certain predictor factors, and when we aggregated those to the geographic area and compared the predicted to the observed, the prediction was higher than what was actually being observed. So I hope that kind of shows some of the potential within data. I feel like there's a lot of other potentials that I could talk about, but I guess that what I'll summarize with is that big data has a lot of potential, and these two illustrations that I've shown here from the city of Hamilton and from the county of Renfrew show how sort of digging into data has a lot of potential, and I hope that I've illustrated some of the story. What I deal with now, I say I'm sort of like a kid in a sandbox where the data is the sand, and sometimes it feels like somebody else has been in the sandbox already and throwing some of the sand out. It is something that's challenging, but I think that it's something that I enjoy and that I'm excited to continue in. So that brings me to the Carpe study. Not sure if anyone is a Dead Poets Society fan, but I used the carpe, the Latin word to pluck, to kind of go along with this idea of data being the sand in the sandbox and trying to find those kernels, those indicators, the risk factors associated with repeated paramedic service encounters. And that's really the basis of what I'll be working on going forward. So I'll wrap up there. Special thanks goes to Nico Yannikolias, who was my supervisor during my master's, Brent McLeod, Mike Nolan, Michelle Rouet, and Andrew Costa. And here's some of the reference material that I was talking about. And I'll open it up to questions.
Great, Matt. Thank you. Before I open the lines up, I want to ask a question. I heard you say that you expected greater demand in the afternoon and evening hours, but I'm not sure I caught why you anticipated there would be higher demand in those two time slots.
That was out of the paper from Scott and Scott, Strickland, Warner, and Dawson. This paper here. So they looked at the most frequent callers to the ambulance service within a 1-year call data, and they found that the demand was higher in the afternoon and evening period.
Okay, great. That was the tie that I was missing. Okay, we're going to open up the lines then for people to ask questions. Here we go.
The conference has been unmuted.
Anyone have questions for Matt?
Yeah, Matt, this is Mitch from Olympia, Washington. How you doing?
I'm doing well.
Okay, thank you very much for presenting. Appreciate all the information that you have there. One of the things we've been working on is just a proper data collection system. Do you guys have anything in place that you're collecting that's different than your normal EMS records management?
So the data that I used from the city of Hamilton was collected through their dispatch system, and then the data from Renfrew was through their EPCR. And both of those are, standard across the province of Ontario. I don't know if there's really any differences there. I guess what I can speak to is that so both services provided me the data, sort of the key element that I was talking about in my introductory sort of slides was how it was all incident-based data. And so within the data, there was a unique patient identifier that I used to aggregate the data to the patient in order to determine whether or not they were a repetitious user, how often they were, how mobile of a user they were. And all of that data aggregation and analysis I did using SAS, which is a statistical software package. So I hope that helps you out. I think that in my experience, at the front end, generating the data, I think that it can be done in a variety of ways, but once you get into the analysis side of it, using something that's a bit more powerful of a software package is going to be the benefit.
Oh, very good. So it looked like the data that you were using was centralized to a couple of organizations. Does the dispatcher records management systems across Ontario, are you able to share collective data of all the different responders or response organizations, or are they still kept independent?
So there's a couple of different challenges there. One is sort of the multi-level system of administration within Ontario. So for the most part, the dispatches are under the purview of the province, and they're regional, where the paramedic services themselves are municipal. And so there is within the dispatch system the opportunity for more sort of cross-boundary and standardized sort of even, I believe, between dispatch, even between dispatch centers, it's a standardized way of sharing, transferring calls between vehicles, or it doesn't matter which service is doing it. And so all of that data, when it gets passed over to the municipalities, reflects what that municipality has done, whether it's within their borders or not, and whether a neighboring service has responded within their municipal borders. But within the municipal level of the paramedic services, so like the electronic patient care records, there is not really any integration with other healthcare services as far as when that patient call record is completed. It is a one incident, and if it gets married with the patient record, it's up to the hospital, which is separate from the paramedic service. And so there isn't really this. There really is not the ability to look at where patients are mobile between municipalities or between hospitals. Even it's really challenging.
Right. Yeah, and that's one of the biggest problems in the States here. You know, we have a HIPAA law. I'm not sure if you're familiar with that. It just is a patient protection of health information, basically. Do you guys have that across Canada? Is that something
yeah,
that
it's certainly a barrier. From a research perspective, working as a researcher, I have a little bit of leeway in that the services can generate those unique patient identifiers so that they are not sharing with me personal health information. So there's nothing identifiable within the data. And that was one of the advantages also of using the location based on the dispatch grid as opposed to being based on the patient address.
Oh.
So yeah, that was definitely to my advantage as a researcher to be able to work with data that didn't have anything identifiable in it, but when it comes to integrating data, that's something that I think, yeah, there's a real challenge there around privacy. Absolutely.
All right. Huh. Very good. Well, thank you very much for the information. I appreciate it.
Hi, this is Zion from the United States, and I have a follow-up question about the patient identifier that you mentioned, as well as the model you used from Scott and Strickland. You said that the various services provided you with the data and already stripped everything down to a single patient identifier. Would you happen to know how they concocted the patient identifier such that it was reasonably accurate? Because I would expect that patients don't consistently give out to their names in the same spellings or the same addresses and so forth.
Yep, that's something that I think was probably a larger issue, particularly within the dispatch data. My understanding is within the dispatch data, where it was a repetitious user, that the name was associated historically with the location of the call, and therefore that's how they could generate the identifier. How they actually did that, I'm not entirely sure. As I said,
that's fine.
That's
sure.
how it was presented to me.
Right, and then, okay.
Within the patient care records, that has a lot more information around address, date of birth. In the province of Ontario, there's a provincial registry for health insurance, which has a health card number associated with it. So there would be a much stronger ability to account for differences in spelling or addresses, or therefore because of a number of different fields that could be used to link together to create the identifier.
Okay. And then you also mentioned that you took your model based off of the work done by Scott and Strickland in their 2014 paper. What sort of validation did you do to make sure their model would be a good fit for your particular environments of study?
Sure. So their paper, and what I was saying, that the findings that I had were consistent with their findings, and that was really just it. That their findings suggested that the most frequent callers tended to call in the afternoons and evenings, and they spoke about how sort of there's, if I use a scenario like, say, a patient who receives home care services, it may be that it's when the other care provider comes to the home and recognizes the problem, or that there's been some interruption in the regular routine, or that they're calling because they weren't able to get in to see the appointment that they had with the clinician, say, during that day, whatever. And so that was the findings of that group, and so we just assumed that based on their findings to have a similar expectation of that later in the day temporal trend, and that's what we found. Okay,
I see. And then I expect that then you used the demand mod results from that model to notice that the community paramedicine was paying off.
Well, in the
yes, okay.
In the Hamilton one, it wasn't so much that whether or not, because they didn't have a mobile intervention, so the results indicated locations where they could potentially target for future intervention, or if they were to employ some sort of mobile intervention, where and when the demand would be.
Okay, thank you.
Mm-hmm.
Any other questions? All right. Well, Matt, thank you very much for being here. Will you be able to join us in Saskatoon in June?
That's my plan. I hope to be there, yeah.
All right. Very good. Well, just a couple reminders to everybody. We do have our meeting coming up in Saskatoon in June. We'll have about 30 different presenters at that session. We'll have a schedule of events ready in a few weeks. We don't have that quite set up yet, but we have some great presentation proposals. And then also, just as a reminder, if you missed it on the front end, we've switched over to a email service, vertical response, and so we're dismantling our Google group. And you'll need to opt in to vertical response, and you'll have the ability to opt out whenever you choose to using the same service. It'll be a little bit easier for us to manage as well. So if you didn't get the link for that by email, you can go to ircp.info, and there's a link on the right side of the page to opt into our email system. So thank you very much, and we'll look forward to having you all back with us again a month from today. Have a great afternoon.
Thanks, Gary.